Guys, we will wait 10 more minutes while others log on. Welcome and thank you for joining the lung function testing webinar today. My name is Maria Bejarano from Esperanza Community Housing Corporation in South Los Angeles, and I will be moderating today's webinar. Before we begin, I would like to start off with some webinar logistics. Everyone on the webinar will be muted. If you have comment or question during the presentation, please use the chat box to send a chat to all participants. The presenter may miss a comment, it is a direct message. The webinar will be recorded, so you can watch it again in the future if you wish. The link will be included at the end of the webinar. At the end of each webinar, there will be an evaluation that we will open in a separate window. Please take a minute to fill out the survey to help us make each webinar better. Thank you in advance. This six-part webinar series was developed from the Asthma Management Academy, a professional development opportunity developed in 2016 by the California Department of Public Health, Esperanza Community Housing Corporation, and Comité Cívico del Valle. The Management Academy was developed for community health workers and health educators to support them in educating their asthmatic clients on self-management and prevention. This is the third webinar in the six-part series. We will host this one-hour webinar once a month. Our webinar topics were chosen and prioritized by the Asthma Management Academy participants and include pulmonary function testing, reproductive health and asthma, and healthy home, among other topics. Each month, we will hear from a clinical and community subject matter expert The presenter will have time for question and answer at the end of the presentation. Our topic today is, of course, lung function testing, and we will be hearing from Dr. Gina Johnson, a pediatrician with Northeast Valley Health Corporation, who regularly works with asthmatic patients, and Rosa Garcia, a promotora and team leader. Now we will be beginning with Dr. Johnson and Rosa presentation. You have 20 minutes together for the presentation. Doctor?
Great, thank you so much. It is our pleasure to share with you a little bit about lung function testing. This is Gina Johnson, and I have with me also Rosa Garcia. And I'm trying to move the slides so that you can see our next slide.
We have some difficulties. Be patient.
I am having difficulty, so if we can just, whoever has control of the slides, maybe move to the next slide.
Could you use your arrows to advance the slide?
I'm trying.
Okay. I'll go ahead.
Okay, great. Thank you so much. So our learning objectives, we can go to the next slide. Okay. Our learning objectives are to describe the use of spirometry in the diagnosis of asthma and the determination of the disease severity, and also to describe the use of the spirometer and interpretation of results. And on our next slide, we wanted to know, so if you can just chat in what you want to learn today, what you would be interested in learning on today's webinar. And on the next slide, you can see that there's a little poll as well that we want to learn a little bit about use. So feel free to click on that link and tell us a little bit about you. It's just 4 questions, and we wanted to find out about you. And also feel free to chat in now and throughout the presentation any questions that you have. Okay. All right, so we'll go on to the next slide while you're still working on that. And what is spirometry? Spirometry is made up of 2 words, spiro, to breathe, and metry, to measure. So what are we measuring? We're measuring how much air is being exhaled, as well as how quickly that air is being exhaled. So we look at both the volume and the flow while we are doing spirometry. Next slide describes when and why spirometry should be performed. So there's a couple of reasons. One is to obtain an objective measure of lung function, and these are the times that we recommend, that it's recommended to perform spirometry. At the initial assessment to determine if someone has asthma, after the treatment has been initiated and the symptoms are stabilized, during periods of progressive or prolonged loss of asthma control, and at least every 1 to 2 years, and more frequently depending on the response to therapy. And we're going to share at the end of our presentation some cases that speak more to when we perform spirometry, and we'll also talk as we go along on why we use it. On the next slide, we talk about more about why we use spirometry. So the NHLBI asthma guidelines, it's the National Heart, Lung, Blood Institute national guidelines, and my personal favorite, the Global Initiative for Asthma, or GINA, which is my name, both recommend using spirometry for an objective measure of lung function. It quantifies the severity of airflow obstruction in the same way that a blood pressure recording with a blood pressure cuff quantifies hypertension, and a glucose monitor quantifies blood sugar levels. So you can't imagine treating diabetes without knowing what people's blood sugar is, or high blood pressure without knowing what their blood pressure level is, and the same thing with asthma. It helps us to determine diagnosis and treatment. So the next slide will talk more about why we're using spirometry before diagnosis and after.
So why we use the spirometry for pre-diagnosis. That's one of the ways why we use the spirometry. And only the spirometry is one of the procedures that can help to show the reversible on the bronchoconstriction, and that, of course, consists with asthma. Just a physical exam alone is not actually reliable for excluding other diagnoses or categorizing the status of lung impairment. On the pre-diagnosis, of course, we provide a starting point for treatment for the providers and the selection and plan and medications. For post-test or post-diagnosis by using the spirometry, of course, that will help to monitor more effective on the treatment, including the medications. It helps to guide to the stepwise to treat the asthma. And the peak flow monitoring and asthma control test together with the spirometry produce a more complete picture of the control of the asthma.
So the next slide will talk about how it works.
So the spirometry measures how much and how quickly air can be expelled following a deep breath. The patient breathing out forcibly for 6 seconds into the spirometry machine. And we also can use the pre and post bronchial dilator. The spirometry should be done when the diagnosis of asthma is being considered.
So the next slide talks about the various components of spirometry, and we're going to go through these pretty quickly so that you guys can get a sense of what all you can learn from spirometry. So there's the FVC, the FEV1, and the FEV1 over FVC ratio. That's really what we use to determine most commonly. The peak expiratory flow is a little bit more controversial with regard to diagnosis and level of control. And then the forced expiratory time, the FET, has a minimum time based on the age of the patient. And the next slide talks about more specifically each of those components. So the forced vital capacity is the maximum volume of air forcibly exhaled from the point of maximal inhalation. So how much air is inside of the patient's lung that we can measure? So there's always a little bit that stays there and we can't measure, but this is as much air as we're able to measure. The FEV1, or the forced expiratory volume in 1 second, is the volume of air exhaled during the first second of the FVC. So that tells you, that's about speed. It's about the how quickly the flow goes. On the next slide, it shows a little bit of how we measure these components. So the volume is on the x-axis, and that's liters, so how much, and then the time is on the y-axis, and that's how many seconds. The next slide gives you a picture of how that works. And so the forced expiratory time there, we like to have in older patients particularly at least 6 seconds of blowing in the maneuver, and we'll talk a little bit about how that happens. But essentially, we want to see that they're able to blow for at least 6 seconds, and then the FVC is the maximal amount that they're the volume, so that's the top number, and then the FEV1 is the maximum volume in that first second. So that tells you a little bit about how fast the air is able to get out. The next slide talks about the ratio of the FEV1 to FVC. This is the thing that we use the absolute most. It's calculated as, the calculation is expressed as a percent, and we call that the percent predicted, and that assesses the severity of disease, and we'll look about that a little bit more in a second. But basically, the FEV1 divided by the FVC gives you a percent predicted. On the next slide, it talks about the fact that those percent predicted is based on age, height, sex, race, and then we're able to compare that what the percent predicted turns out in our patient, compared that to NIH-based guidelines of what we should be expecting. Really important. I'm a pediatrician, so you know that a 6-year-old can be the size of a 10-year-old or it can be the size of a 4-year-old. So their height really makes a huge difference, not just their age. And then race and gender, so male and female, also have some variation, but probably the largest variation is with regard to their height. So it's really important that they have an accurate height when you're determining how they compare with what we expect. The spirometer tells all. That's the next slide. This is an actual picture of our spirometer. And then in the next slide, we can talk a little bit about the predicted ranges. So the values for FVC and FEV1 that are above 80% of predicted are defined as within the normal range. So the FEV1 over FVC ratio needs to be at least 80%. And pediatrics, the normal FEV1 is more than 80%. The normal FEV1 over FVC or percent predicted varies depending on how old you are. So young people, they have all this wonderful lung capacity, 85% or above should be normal. As you get older, that's the reason why I can't run marathons as fast as I used to. You have less lung volume, so by the time that you're in the 60 to 80 years, it's normal to only be at 70%. So it's really important, again, for us to be sure that we have the proper age, the proper height, so we can compare what results we get with the actual expectations. The next slide talks about the final component of the spirometry results, which would be the peak expiratory flow. So that sounds very similar to a peak flow, doesn't it? Essentially, it's the same thing that is measured with a peak flow meter, but in this manner, you're able to look more specifically at the peak expiratory flow as well as all of the rest of the numbers that we've been looking at. There we go. The next slide tells us, why do we care about all of these numbers? Interpretation. What does spirometry tell us?
So when we do spirometry, we can actually find out if there is obstruction or there is a problem of restrictive into the lungs.
So if you look at the next slide.
So if you look at the next slide.
Oh, our pictures did not come up. Okay.
Okay, well, so when we're talking about obstructive, we have like a very nice picture on our side, but we can still see it there. So obstructive means that FEVC normal, but FEV1 abnormal because the air cannot get out quickly. And restrictive, you can see there is a abnormal FVC.
Next slide.
So for obstructive, we can look into, when we do the spirometry, of course, not only asthma diagnosis, but we can also see a COPD. And we can also be able to diagnose by the providers the bronchiolitis, cystic fibrosis. And then on restrictive, we can look into there is maybe obesity, interstitial lung disease, scoliosis, neuromuscular disease, and sarcoidosis.
So the next slide looks again at this. Hopefully the pictures will be on this one. Yes, there we go. So what's the difference between obstructive and restrictive? So obstructive means that the volume of air in the patient's lungs is normal, but it just can't get out as quickly as it should. So you can see in that picture of the asthmatic bronchiole, it's all plugged up. It's like trying to drink from a straw when you pinch it. Not as much volume can get out. So in that first second, you can't get as much out as you normally would. But if you keep sucking on that straw, you're eventually going to empty the drink. So the same thing with the lung, right? The lung volume is the same, but the amount that goes out quickly is not very much in obstructive diseases like asthma, like COPD, like bronchiectasis or cystic fibrosis. In restrictive lung disease, their lungs are not the right volume, so the FVC is going to be decreased. So they don't have as much lung volume, but they have a normal FEV1 over FVC ratio. So in that first second, they can get as much air out as anyone else, but they just don't have as much air inside of their lungs. So I would say the thing we most commonly see that demonstrates a restrictive lung pattern on spirometry is obesity. So most commonly, our patients are just, their lungs are restricted because of their body habitus, so they're not able to demonstrate the same amount of volume. The next slide is a little bit of a busy slide, but we wanted to talk about what you can really see in spirometry. So there's two things that we're looking at. Is airflow obstruction present? And is it at least partially reversible? So on the left-hand side of this slide, you can see we can use spirometry to establish that the airflow is obstructed. So that FEV1, once again, the amount of air they can get out in the first second is going to be less than it should be. And the FEV1 over FVC ratio is going to be below the lower limit of normal as compared with the individual's own predicted value. So they have the same amount of air in their lungs, they just can't get it out as fast. Then with spirometry, after you've determined that they have the right volume and it can't come out as fast, we need to see, is that reversible? So can we get them to a place where they actually are able to get out as much air as they should in that first second? And so there's three different ways that you can look to determine if it's reversible. One is that the FEV increases more than 12% after using albuterol. So what we typically do is we do a test to demonstrate their ability to exhale air quickly, and we get those numbers, the FEV1 and the FEV1 over FVC, and then we give them a treatment with albuterol, whether their own inhaler or a nebulized treatment in the office, and then after that's had time to go into effect, we repeat the exact same test. If their FEV1 increases by 12%, that means that their forced expiratory volume in that first second increases by a significant amount. That's not that would not be significant only from chance alone. That means that we're able to reverse their obstruction. Also, you can look at the volume. So if they get an increase of more than 200 milliliters after using the short-acting beta agonist like albuterol, that's similar. Also, if we put them on an oral or a high-dose inhaled corticosteroid, and then a few weeks later we try it again, and now their FEV1 has improved significantly more than 12%, that also would suggest that it's reversible, because by treating them with steroids, we were able to reverse their obstruction. Asthma will improve really quickly with albuterol use, so you're going to be able to do that immediately after you can do the test within a few minutes. But sometimes if they have COPD, they might have, you're not going to see as much of a quick response. And if they're restricted airways, then you're not going to see a response, because the problem is not that the bronchioles are obstructed. The problem is that they don't have enough lung volume. So you're not going to see a significant change after the albuterol use. There are some reasons that you might not see improvement even if they truly do have reversible airflow obstruction. So if the patient used their albuterol 30 minutes before testing, then even if we give them an albuterol treatment, it's not going to improve, because they're already maximally bronchodilated and their initial test was actually at bronchodilation. If they just have a very mild airflow obstruction, then you might not see a full 12% change in their airflow obstruction after using the albuterol. If they're already on a maximal bronchodilator medication because they're so friable with their asthma that they can't go off, then you're not going to be able to see that reversibility. And certainly if they have asthma with an airflow restriction such as a COPD overlap syndrome, then you might not be able to see that full 12%. So the next slide is directly from the NHLBI guidelines. And in the middle of the page, you can see where it talks about lung function. So this is, as we said, the ability to assess asthma severity depends on, of course, symptoms, and depends on hospitalization, some interference with activity and everything, but we use whichever panel the patient falls into that's the worst. And so if you don't have these numbers, then you're only able to assess their initial asthma severity based on their symptoms. If you have these numbers and the patient's FEV1 is in the 60 to 80% range, even though they're telling you that they only have 2 days or less a week of symptoms, you're still going to put them in the moderate persistent category because you use whichever is the worst. And this is, again, an objective measure of their lung function. And, again, sometimes people just don't recognize how unwell they are until we can give them the proper treatment and help them to be better. The next slide talks about asthma control. So once we've determined what their level of asthma is and they're coming back for follow-up, then we want to look at their asthma control. And once again, we're going to use their symptoms. We're going to use a standardized test like the asthma control test or the ATTACK or one of those questionnaires that you ask the patients. But when we have spirometry, we can also use those numbers to determine their level of control. So again, if they fall in the 60 to 80% range, then even if they're telling you everything is great, then they're not well controlled, and we need to step up their medication regimen. So it's really important for us to have these objective numbers. We're going to share a few cases with you, if you go on to the next slide, which are demonstrate sort of how we use spirometry in our health center. So the first case is a 5-year-old patient who came in for their well-child exam. Mom was concerned that the patient might have had asthma based on shortness of breath, coughing while playing soccer, and wheezing at night. The patient is also obese and also snores, so it's a little hard to see if it's an upper airway obstruction or if it's a true asthma picture. So we ordered spirometry with albuterol use, pre and post albuterol spirometry. And on the next slide, you will see our slides, our actual test.
So this is our one of our cases, or actually one of our patients. And I received a referral from the provider to do a pre and post spirometry. I have to make sure when the patient comes to their visit, then they have not used any albuterol before they come for the test, and also they do not have any oral steroids, at least in the past 4 weeks, and then make sure then they don't have severe cough and wheezing, shortness of breath at that moment. And we do the pre-test. And if we're looking at the left side of the picture, you can see there is like a little scoop on the graph, and also the peak, and that's what we're looking into. And of course, providers will look also on the predicted values, and you can see on the below part where we can see that FEV1, FEVC, it's 84, so it's actually below the 85 that we're looking into as a normal value. But this is not ending here, because then we do the treatment of albuterol, and then after the treatment, we wait for at least 15 minutes for the medication to actually work on their lungs, and then that's when I start doing the post-test, which is exactly the same test, no difference from the pre-test. And then you can see on the right side of the graph, there's no more scoop anymore right there. And then also the peak, you see it's changing now, so it looks more wider. So that's when we look into the change. And then when we're looking on the numbers, so change on below on the numbers, you can see on the red number on change, the FEV1, it's a 20% change. That's flagging that definitely this patient has asthma.
So the next slide just shows you how long the patient was able to blow for. As I mentioned, we want them to go at least for 6 seconds if they're older, but in this case the patient was 5 years old, so they need to go at least for 3 seconds. So again, we can see from this case that the patient had reversible obstructive airflow, and that's consistent with asthma. The next case is on the next slide, and it is a 7-year-old patient who had 4 emergency room visits within the past year, multiple oral steroid visits, had been prescribed an inhaled corticosteroid but was out for the last month, and according to the parent at that visit, had not been using their albuterol much. They were seen by their provider, who advised the patient to resume their controller medicine and referred them to our asthma educator for spirometry. And in the next slide, you'll be able to see the spirometry test in this patient's case.
So if we see on this test, the graph, it shows again, you see the scoop right there on the graph and also the peak. And remember, as instructions from the case, this patient has not been taking their controller medication, and they've been probably having a lot of symptoms, but they haven't really said it to us.
So that's the story that we got. If you look at the percent predicted there on that slide, the FEV1 is at 76%, and the FEV1 over FVC is at 82%. And so despite the family telling us that the patient has not been using albuterol very much, the lung function is not very good. The next slide talks further about this case. The patient was scheduled for a follow-up 2 weeks after their spirometry visit with their primary care provider. The patient set a self-management goal, which was to use her controller medication as instructed. The family was invited to our asthma group class the following week, where she received a mattress cover. 2 weeks later, she was seen by her PCP and was still not using her controller medication. But according to the family, they were going to pick the medication up that day, and they were going to begin to use it. Over the next 2 months, the patient was seen regularly, seemed to be doing great, had a good asthma control based on their symptoms and based on their asthma control test. And then the next slide reveals the next visit was scheduled for 3 months after the patient had been well controlled. They missed that appointment and didn't reschedule, but about a month later, so 4 months after those visits, we received notification from our population health management software that the patient was in the emergency room for the 5th time in 12 months. We had our asthma educator call the family to schedule an appointment for a provider visit and also to repeat spirometry. At that time, the mother explained to the asthma educator, "I knew it was just a cold, but her father said she needed to go straight to the emergency room. At the emergency room, they prescribed medication, but I didn't even get it because I knew she was not having asthma symptoms. It was just a cold." And this is the spirometry test on the next slide that was performed 1 week after that visit.
So after that visit, we did the spirometry again, and of course, we find out that the patient was actually now taking their controller medications, and that's what the spirometry also helping us to assess the compliance with the medications. And if you can see the graph, it doesn't have the scoop, and it doesn't have the peak anymore. And if we look at the values, we can see that FEV1 increased so well because now we are on 101. And also, if we're looking into the FEV1 and FEVC, the increase was amazing because now we're getting 90% of what we're looking into of the normal, even above of the normal because of the compliance of the medication.
Exactly. So if you look at the next slide, you'll see Mom was right. It wasn't an asthma exacerbation, it was just a cold. And so the asthma educator was able to reinforce appropriate use of the medication of the emergency room, and then was seen follow-up 2 weeks later by the PCP just to reinforce the current regimen. So just to echo what Rosa has said, typically if you have an asthmatic patient who winds up in the emergency room for asthma symptoms, you think this patient's not well controlled and you're going to go ahead and increase their medication, and especially given the fact that we weren't clear on whose story was accurate. Was it Mom who said that it was just a cold, or was it Dad who said, no, it's an emergency, we got to go to the emergency room? So spirometry was really helpful to help us demonstrate that this patient actually is well controlled as long as she continues to use her medication. Our next slide talks about our third case, which is a 16-year-old patient who came in for a sick visit. This patient was coughing, had noisy breathing, had a family history of asthma, was obese. We didn't know if it was asthma. We didn't know if it was upper airway. We didn't know if it was restrictive lung disease because of the body habitus. And so we didn't do spirometry at that exact visit, but we ordered spirometry, pre- and post-albuterol spirometry, to determine if asthma was what was complicating this patient's picture. And in the next slide, you'll be able to see how that test looked.
So in this case, we can see that the pre-test on your left side, it's a perfect curve. There is no any scoop, and the peak, it's good. And then we look into the predictor numbers. We can see on the FEV1 on the below part, and the blue numbers, we can see the FEV1 is 98%. And the FEV1 FABC is looking into the 93%, which is the normal values. We still have to do at this point the pulse test, because we want to make sure to find out if there is any changes, as we mentioned before. So in your right side, you can see the graph, and if you visualize both graphs, you can see they look identical. So it's really no change by the graph picture, but we're still looking into the numbers. And if you look into the change after the albuterol, we can see the FEV1 did not change at all. So we can see there is a 0% change. So that's how a spirometry actually helps on all this control. In the previous case, we discussed that we could find out that patient was actually compliant with the medication, it was well controlled. In this case, we're looking into that patient needs help or not in regards to diagnosed asthma. We were able to find out the patient is not asthmatic at all at this point.
Yeah. So the next slide just shows you that this patient was able to blow for a good 7 seconds, so we really got an excellent test done. The next slide talks about why spirometry versus peak flow. Peak flow is quite effort dependent, and both actually, spirometry and peak flow are very effort dependent. But with spirometry, you can detect how much the effort impacts the results. So we here at Northeast Valley will have our asthma educators do the spirometry test. And if the patient's effort level is, it actually grades their effort level, the spirometer itself, and our educators also are well versed in what's a good test. So if it looks like the effort is poor, then we don't use that information to determine our assessment of the patient's asthma. With a peak flow, there's no way to determine if it was a good effort or not a good effort. So we sort of have to take it at face value. If you were in our building while one of our asthma educators is doing spirometry, you would hear what sounds like a football game for blow, 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 blow. And so Rosa or our other asthma educator is cheering the patient on, blow, 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 deep breath, blow, 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 blast it out, to help to get the best effort possible. Peak flow, on the other hand, is quite useful because it's portable. You can use it in your home. You can see variance throughout multiple times of the day based on the symptoms, and especially that's especially useful for people who don't connect their symptoms with their lung function. And of course, it does not require a visit to a specialist or require special training. With spirometry, we do also find it very helpful for those patients who, like our first case, are a little bit in denial about how significant their asthma is affecting their lung function. So when you actually have a picture that you can demonstrate what their lung function looks like, and you can actually show them numbers that demonstrate what their numbers are compared to another person of their age and their height, it helps to really reinforce their level of control, their need to be compliant with their medication. So we really have found that very helpful. Next slide talks a little bit more about why we use peak flow In our organization, again, we use it for our adult patients who don't have access to spirometry completed outside of Northeast Valley. So our asthma educators are fantastic, and they are spread thin for our pediatric patient population. They're able to do spirometry on all of our patients, pediatric patients, 5 and above with asthma, but we're not able to do our adult patients in addition. So we are able to refer them out, and sometimes access is excellent and sometimes not so excellent. So if we cannot get good access to spirometry, then we would do peak flow. And then certainly there are patients who are just poor perceivers. They don't recognize their asthma symptoms, and so they are needing to have a peak flow meter to use on a regular basis when they can't come into the office. The next slide talks about our asthma resources.
So besides all the good we can offer the spirometry here in our clinics. Of course, we also offer the education part. And by doing the asthma group classes, we use the NHI curriculum. And then you can see we have the link that you can actually use that and go into. The providers also have the same curriculum in the clinics and the desktops and the computers, so we can connect exactly the same message to the patient from the provider's perspective and from the educators. We also have a one-on-one sessions, and that's specifically based on the provider's request. And we also have health education materials, like right now we have a booth in every clinic for the Asthma World Day, and we're offering all those handouts and educational information to our community. And 1 degree social determinants for health.
So we found that, so just to reinforce a little bit on our asthma group class, so all of our patients with asthma, we like to refer them to the group class. It's a 1 hour class, 2 hours, I'm sorry, and a half. Class that they learn all about asthma. It's a video-based curriculum which is free from the NIH, so anyone can access that and have the videos as well as the curriculum. And then in our office we have a little 5-minute, 3 series of 5-minute talks that are based on the same curriculum for the provider that also comes out of that NIH guidelines, NIH curriculum, and it's a flip chart. In the olden days it was a flip chart that we actually had to flip through in the patient rooms, and now we have it on all of our computers as well so that we can go through that. And then if we feel that a patient needs more intensive education, then we can send them for a one-on-one session with the asthma educator. What we have found is that our patient needs are greater than just education about their asthma and their triggers. Sometimes their triggers are unavoidable because they have cats that are milling around their house that don't belong to them. Sometimes they live in garages and they don't have good ventilation. Sometimes they have other stressors that affect their ability to handle their asthma. So maybe they have food insecurity and they're unable to be sure that they're going to have food for tomorrow, so that stresses them out and causes their asthma to flare. So we have a wonderful online resource which is called 1 Degree, which we can refer our patients to for the social determinants of health. That's LA County and the San Francisco Bay Area in California are populated with that, and it is sort of like a Yelp-like social services platform where they can access in real time their needs, and they can get a text message or an email or a printout of where they're going. So that's really helpful for us in addition to our fantastic asthma educators and all of the other resources that we have. So that ends our presentation on why we use, how we use spirometry, and if there are any questions, we would be happy to answer them. So you can feel free to chat in any questions that you have in the Q&A box or in the chat box. Is there a way to have access to PowerPoint? I see. What spirometer is the best to use? I see. That's a question. We think, I'm going to let Rosa speak to it, but we think that the most easily accessed spirometer is the best one to use.
Yes, so I'm agree with that. So I've been doing this for about 10 years already, and we've been using the easy one, the one that you look at the picture, and that's just the basic one and nothing sophisticated. I think that would be the most effective one, as simple.
So they now have all kinds of technology, which is amazing. Even with the spirometer that we have, where they can, it hooks up to the computer and it has little graphics. So the most commonly used one that Rosa uses is a little bubble, and then they have to pop the bubble. But they have like blow out the candles on the cake and little swinging monkey and that sort of stuff, which is helpful as an incentive to get them to blow. We have looked at how we can, our spirometer does not feed the results directly into our electronic health records, so they actually have to type that in. Some spirometers go directly into your EHR, and they communicate that way. I think each organization needs to see what works best for them.
As experience for the incentive screen, I think that helps a lot with our patients, especially because they're pediatrics, so they get a lot of motivation when they see those graphs. Not only the graphs, but they see the picture itself with the little kid with the balloon, so they get excited about it. So it helps me a lot for them to give me a better effort when they do the blow.
So the cost of spirometry is actually, I'm seeing more questions, is actually based on the spirometer itself as well as your staff time to do it. So we are really lucky to have a asthma educator that originally was grant funded but now is actually part of our budget, because we know that it really is such an amazing resource and improves our patients' health. The spirometer itself is about we'll say about $900, because you have to get two different parts. You have to get the spirometry, and then you also have to get the griddle, and of course including the mouthpieces, because those have to pay separately too. And then plus, when it's the first time, you have to pay for the software. Mm-hmm. So that's what includes all the price. Yeah. Right. Yeah. CHW, it's a billable. You can bill for the spirometry visit, but it because it's included in our PPS rate, it doesn't actually make us money. It's still well worth it. Long-term effects of using daily medications and inhalers to treat asthma. What we know is that uncontrolled asthma has very significant and severe long-term effects, including permanent damage to the lungs, of course, but then the costs related to missing school days, missing work days, and quality of life metrics can be very, very high. And so a patient that's not well controlled with their asthma really are at high risk for having chronic health problems in addition to school failure, and their parents, of course, are not able to attend work, and that can be very costly. The long-term effects of using an inhaled corticosteroid, if used appropriately, are very minimal. So appropriately means, of course, that the patient is using, if they're using an MDI, they're using it with a spacer, or if they're using a dry powdered inhaler, then they're using it appropriately, that they rinse their mouth out after they have used the medication, so that they're not absorbing a significant amount. In a small child who's using it via nebulizer, you want to have a tight-fitting mask and the same rinse their mouth out after they use it. And then you want to use the appropriate dose. So if I go back to case 2, where our patient had, pretty significant asthma symptoms, or asthma and poorly controlled asthma based on the spirometry numbers initially, and then went to the emergency room for another visit, which mom swore was just based on a cold. As I said, if we had not had the spirometry numbers, we probably would have increased their medication, which would have certainly put them at higher risk for side effects, which the most common side effects are in children, decreased growth. So we do see our patients routinely and measure their height to make sure they're growing well. And in all people, you can have a decrease in your immune system. So increased risk of viral infections. If they're not rinsing out their mouth appropriately, they can have an increased risk of thrush and oral fungus inside of their lungs.
And then for that question, also we're looking into it from the provider's perspective to prefer, and that's what I'm teaching, is for them to, it's safer for them to use corticosteroids on a daily basis than ending to have oral steroids treatments so often that through the time it's going to get more worse side effects than using the corticosteroids, because the comparison from a doses of oral steroids for 5 days, it's an amount of about 6 months of corticosteroids on a daily basis. That's a big change. I mean, strong medication, oral steroids, and that's what we're looking into avoid when we do the teaching to the parents to be compliant with the controlled medication.
So inhaled corticosteroids do not get absorbed very significantly in the body. Obviously, oral corticosteroids like a prednisone or prednisolone gets absorbed immediately and goes all throughout the body, doesn't just stay in the lungs. How does the patient get a spirometer test, and can a pediatrician request it, and does Medi-Cal pay for the test? Yes, so actually, as I said, our pediatric patients we usually do it in-house, and we found that it is very cost-effective for us to do it in-house, even though as a FQHC we don't get paid for it. But if you're straight Medicaid, then you can, Medi-Cal, then you actually can bill for it as a test in-house. And our adult patients, we send them out to pulmonary or allergy or to the pulmonary function test without a specialist visit, and we're able to just do that referral to our local partners, and then they actually do the test and they send us back the results. So most allergist offices have a spirometer, and they can do an in-house test, and most obviously pulmonologists can do more extensive pulmonary function testing as well. Do you have to be licensed, or can anyone do a spirometry test?
Well, I've been doing this for 10 years, and yes, I did receive a lot of training. One of the training was through the Washington University. It was for 6 months, then we get all that training because we had to send data from our clinics. And then it's a ongoing learning. We have to do a reevaluate ourselves, and we do it internally here like every 3 years, and then we have to review all the information about a spirometry, and we get a test through Norris Valley. Then we need to go and review all what we have been learning. It's experience as the way you're doing it, because you get to the point that you need to know not only as learning but experience. Then the child is actually given the effort that you're looking into to get the right amount of air, then the doctor can actually read it as yes or no. That's what I can tell you.
Yeah. So, and there is no special license or degree that's required for spirometry. And as I said, the machine itself gives a grade to the spirometry test, but our asthma coordinators need to assess if they're doing if the test is going well, and also to get some ideas about what the patient needs to do to get a good test.
There is an option on the website that we call Spirometry 360. Yes, anyone can be able to get into and get the training. And that's so far, that's the training that we use here in Northeast Valley. It's Spirometry 360, that's the name.
What are barriers to spirometry? So many. And, you know, it's such as we talked about how important of a test it is and how useful it is for us. One, the patient has to be in the building well enough to perform spirometry at the time as the person who's going to do it. It takes at least 30 minutes, I would say, for a experienced patient with one of our amazing asthma educators to do regular spirometry. If we're talking about pre and post albuterol spirometry, you're talking, you know, at least an hour that they're going to take. And if it's a 5-year-old or a ADHD patient who's 15, right, or not, you know, anyone, it gets more complicated. So it takes some time. It's not something that we as an organization ask our staff or our providers or our medical assistants to do, just because of the amount of time that it takes. So that being said, our amazing asthma educators travel to all of our clinics. They're not always at the site that I'm at the time that I'm there. And not all of our patients have access, you know, transportation and easy lives that make it easy for them to come back to a follow-up visit. Just to have a test done, and then, you know, they're going to need to hear the results of that test as well. So that can be a bit of a challenge. Rosa is amazing to talk with our patients, to help to explain the test, to try to find a convenient time and a location for them to come in. And so we struggle with that. We do it. There are certainly patients, as I said, we don't have the resources at this time to do spirometry in our adult patients. And so, you know, we have to send them out, and that means it's a referral to someplace else, and they have to go through all of the hoops at that place as well, which can be complicated, and then we need to get those results back to us. I don't know what other barriers you can think of, Rosa.
I'm going to take this a little bit as a joke, but I have to deal sometimes with the parents because they want to be the coaching with the patient when I'm there with them. So sometimes we get to the point, as I explain to them in a good way, that I prefer the patient to just follow one coach, and so they're willing to, you know, wait until the patient is actually performed the spirometry. And then it's funny, but I find out then when they're like by themselves, they're able to accomplish more what we're looking into than when the parents are there. But like Dr. Johnson says, I always like, and that's my priority, I call them ahead of time and explain as much possible what I will do so I can get their help to accomplish the test. And that's what I try to do.
Right. So one of the questions that we had actually when that was on our poll that didn't work, I'm sorry, was, you know, if you are able to access information from the patients that you're seeing. So we know that not everyone is maybe in the same office. And so it's really, you know, it can be a challenge if we're not able to access, even if we get the spirometry done, if we're not able to access the results, then it's really difficult to use them. So really important to somehow be able to connect with to complete the circle and connect with the results.
Dr. Johnson and Rosa, I have a couple more questions on my end from the host Q&A. Which is the best test in diagnosing asthma, exhaled nitric oxide test or spirometry?
So the exhaled nitric oxide test is really excellent. I think it's actually comparable. I don't think it's necessarily specifically better than spirometry, but it's completely not effort dependent. But you get closed into a box basically, and then they see how much you're breathing. So that's not something you can do in just any old office. So access is a real issue for the exhaled NO, and I'm not sure that it's ever going to be something that's accessible to everybody, whereas this office-based spirometry is pretty accessible to everybody. It is effort dependent, so there are, I think, you know, back to barriers just for a second, there are some patients that just cannot do the test well, including some of it. We've tried it out on some of our providers, and they just have a really hard time getting that deep breath and blasting out the air for the amount of time. So the exhaled NO, if you can get it in a patient like that, would be really helpful.
Thank you. There's another question. Is it possible for someone's spirometry to look normal, even though they have asthma and are not in a flare-up?
Yes. So that is, I was just talking about that yesterday with one of our providers. So again, if their obstruction is very mild, then maybe their percent change wouldn't be the significant, the 12%. So maybe it would be 4 or 5%. And there's just no way to say that that's not just due to normal variation, at least on that test. But maybe if you repeated it a few times and every time it comes out 4 or 5%, that may make you think that it's truly asthma. It's just very mild. If they're maximally bronchodilated, so let's say a patient is on a controller medication that has a high dose of inhaled corticosteroids in addition to a bronchodilator, a long-acting beta agonist, and they've used it recently, then you might have a completely normal spirometry test after you use the albuterol, but that's because they're maximally bronchodilated. And if you did it at a different time, or if they were, we don't ever ask them to be non-compliant, but if they had been non-compliant for a while with their medication and then you did it, you might see something different. So certainly you need to use the full constellation, and as I said on those two sort of busy tables, whichever area they're at the worst is where you're going to determine their asthma. So even if they're FEV1 and FEV1 over FVC are normal, but they're having symptoms 3, 4, 5 times a week, then you're going to step up their medication and treat them appropriately based on that, not just based on the numbers.
Great, thank you. I know we're at time, but there's one last question. What's the gas exchange and how is it calculated?
So the gas exchange, I think, is a different measure that's with inhaled nitric oxide. And there's another test also that you can use, but spirometry does not. We don't use the gas exchange to determine the level of asthma control.
Thank you.
Thank you guys so much for having us.
I think that is it for question and answer. Thank you so much for being with us. Esperanza, if you'd like to close the webinar, please feel free.
Thank you, Dr. Johnson and Rosa, for a great presentation and for reviewing lung function testing and how it's used in a clinical community setting. And thank you again for joining today's webinar, and thank you to our wonderful presenters for sharing their knowledge and expertise about lung function testing. Please fill out the evaluation when you sign out the webinar. It should appear in a pop-up window. If you have questions about today's webinar presentation, please reach out to Arden Caffrey at arden@esperanzacommunityhousing.org. We hope you will continue to participate in future webinars with the series. We hope to see you all there again.
Thank you.
Thank you for joining, everyone, and have a great day.